We actually reduced our admission time from 17 minutes to 6 minutes.
We've been able to ensure that all patients coming back from the operating theatre are suitably identified with an identity band.
Our wastage costs have been lowered. We've saved 2 staff members along our plating line, and the patients have a better quality, much more acceptable product.
It's all about ensuring that processes are present within the organisation from a grassroots level to senior management that ensure a provision of high quality services.
Within our department, it's very important that we perform quality activities, because then it makes us look at what we actually do and justify why we do things in a certain way, so that the service we deliver to our clients is the most efficient and effective that it can possibly be.
St George Hospital is heading towards reaccreditation, and quality improvement is an essential part of that process. It's a way that we can ensure that the standards set down for accreditation are maintained in this hospital.
One of the really key areas about the accreditation program are its quality activities. Therefore, we expect when we go into institutions to find out what it is about quality that these organisations are doing. What's their quality plan? How have they improved since the last time? So quality improvement is an integral part of the process of undertaking the ACHS survey and accreditation program.
Customer focus starts with recognising and accepting the fact that every staff member is here to serve customers, whether they're internal or external customers. We need to identify who our customers are, then deliberately go about understanding their needs and their expectations.
Our internal customers are our staff, so that are our doctors, our nurses, our healthcare workers generally, clerical, hotel service staff, and our external customers, of course, are the patients that attend the hospital, the community that we serve generally, their family, relative friends, and anybody that has a stake in the services of the health facility.
All people who have some sort of dealing with the cardiac intensive care unit are in fact our customers, as we are to them. This would include anyone from the stores department through to the ancillary services. We maintain and guarantee that we will continue to have that standard of liaison with those customers, just as we do with our patients.
We've got a very significant range of activities in relation to getting input from customers, both internal and external. In terms of our external customers, we conduct post-discharge questionnaires to see how the patients felt about the service that was provided, service providers, food, general comfort issues, and more recently we've introduced a system of managed care into a number of our departments and units to involve the patients and their family more in the planning and giving of care. One of the ways is in the afternoon at the handover report time, we involve the patients in that handover and actually ask their views and opinions on the care that they've received and also the care that they're going to receive over the next couple of days.
We might look at services such as how we handle disposable waste or how we handle sterile equipment or infection control. We might be looking at very important clinical issues in how our clinical management may be improved for an individual case.
For continual quality improvement to happen, you need a culture where you've moved away from the traditional hierarchical structure and you give the power to the people in the front line. You give them the opportunity to come up with the ideas and the solutions and to implement those solutions and then evaluate them.
They need to be encouraged to work together as a team, and that's multidisciplinary teams, not departments working on their own. You need to make sure that they're educated accordingly, that they have job satisfaction, and that they're all working towards the one goal.
The senior managers become the supporters, the coaches, the encouragers, and ultimately the people who can make sure that the frontline staff get adequate support.
The role of management in a quality management program is to provide leadership and resources to the organisation, to encourage staff to be involved in the quality process, to empower staff so that they feel as though they can initiate change.
For management, there needs to be a recognition that most of the problems within an organisation are systems problems. It's not a question of people performing poorly, it's a question of inadequate or inappropriate systems, and it's going to require senior management to be involved in overhauling those systems. I don't think there's necessarily any preferred structure, but there are some key features. There needs to be management involvement, there needs to be education. You certainly need to encourage teamwork within your organisation and equip both your departmental heads and your staff.
Each organisation is different. We've found at Concord the structure that works for us is to have minimum layers between our people at the workplace and management.
A culture for improvement, continual improvement in quality must involve getting the power in the organisation to the frontline staff, setting up quality teams so that those frontline staff know that they've got the support and the opportunity to look at problems, freely examine all the issues involved, and then implement solutions. And if they know that with confidence, then they've got the ability and the ideas to solve those problems.
Measurement-driven improvement, I believe, is the essence of continuous service improvement, in that you're looking at your organisation and the systems and the processes within that organisation and gathering data to look at facts about where you are at the moment and how you might improve that service. I guess it eliminates the myths and the gut feelings that we've worked on in the past.
Staff are becoming more aware of their need to gather information. I would imagine this has taken place over about the last 5 years because they see the importance of having the information at their fingertips to be able to initiate change in policy, change in procedures, change in the way they do things. It's also a very positive thing for them to have the proof and the facts to be able to put forward to management, to be able to show their actual meaning.
We decided to look at the improvement for the admission process because there was some delays on occasions where patients were late getting to theatre, so we decided to look at the actual process from the time the patient walked into the hospital until they were actually admitted into the ward and straight to theatre.
Where is she? Private hospital is it?
Yes. We began by having an initial meeting with people that the admission process actually impacted upon, being the bookings clerk and reception staff, some ward staff and theatre staff, and had a brainstorming session, and the information gathered during the brainstorming session revealed that this was going to be quite a major problem to sort this out.
We quickly identified the fact that we needed to break up into smaller teams to look at different aspects of the process. The 5 teams then went away and worked together to flowchart the process that they were involved with, and we created these flowcharts here for the 5 different parts of the project that we were looking at. Following on from flowcharting, we then went on to do some cause and effect diagrams, and we decided then that we would do some data collection. We did 2 types of data collection. One was the admission waiting times, so as we'd have a baseline to work on for improvement and be able to measure it at the end of that. We actually are still continuing to gather that data now. We also did a patient waiting analysis to try and find out the reasons why patients were actually waiting to come in. Was it because the bed wasn't ready? Was it because the doctor hadn't seen the patient? We were able to then prioritise what the problems were. There was a lot of commonality in the problems across the 5 teams. So we thought, because it was very difficult to manage those 5 teams, that we would pull that back into being one team again.
The theatre manager spent some time out of theatre and spent about a week in the bookings office with Margaret, the bookings clerk, just to actually watch the process from there. She liaised with all those staff, and then if she could see any solutions or what she thought would be solutions to these problems, they were presented at a meeting and everybody had input, including the management, as to how we could make things run more smoothly.
We found that there were quite a few cold admissions, people who had not pre-admitted, so we had no details. We now ring the patient up a couple of days prior to that, get all the details on computer. The booking officer also has a computer in her office so that at any given time she knows exactly how many beds there are available.
We made a definite discharge time of 10 a.m. We looked at staggering admission times so as we didn't have a group of people arriving at one time, and that we could then organise to have our beds ready when the patients were ready.
Bathrooms through there?
The whole exercise was very positive. I think most of the people involved in it hadn't realised what everyone else's job entailed.
We found that because it impacts, and everybody knows how problems impact on another department, that we more or less are inclined to ring each other and sort the problems out before they become a major problem.
We actually reduced our admission time from 17 minutes to 6 minutes, so we were thrilled with the outcome of the process.
We've had an ongoing problem for quite a while with patients coming back from the theatres without any identity bands on their arms or legs. And it became a real problem when we got 2 patients back who had no identification whatsoever. The problem is compounded when the patient is unconscious and can no longer speak for themselves. That is really all we have to identify the patient. So you can understand that when we're trying to give blood post-operatively, or we're trying to give special medications, and we go to check the patient, if there is no armband, we're in a quandary as what to do.
So I could take a week off then.
When the patient leaves the ward, they have 2 identity bands in place, and this enables us to identify the patient through all facets of their surgery. With cardiac surgery, it's a little bit different because the patients need to have procedures done prior to them actually going into the operating theatre. So the doctor would come along to put in the arterial line and would cut off one of the identity bands. Then the patient goes into theatre, and as part of the procedure for cardiac surgery, they often use one of the veins in the legs, but until they get into theatre, it's very difficult to know which vein and which leg they're going to use. So, as a precaution, they prepare both legs, and so the second identity band goes missing. The patient is prepared, the surgery proceeds, and then to get them back to the recovery area as quickly as possible, they're just brought directly from the theatre back into our unit. And they don't have their identity bands, and at no stage has anybody thought to reapply those bands, I guess because they think there are more pressing issues at hand with the surgery. Because it involved a cross-section of the hospital staff, that was theatres, the ward and our unit, that we needed some sort of documentation to actually show that the problem actually did exist and to measure ourselves the extent to which the problem existed.
What we're doing is we're looking at 7 different areas, and we're looking at each different patient. The areas that we're looking at is, does the patient have 2 identity bands? Are the identification bands legible?
We decided that we would do a quality management exercise and just see how big the problem was, to look at being able to brainstorm some solutions to the problem so that the patient safety was maintained throughout the unit.
Has anyone got any ideas? Maybe sticking them on their arms?
I'd talked to several of the staff in the unit and we'd come to a consensus on this, that we would put an armband on some tape on an area of the patient that wasn't going to be interfered with in theatre. We approached the ward and had a brainstorming session and sat down and really nutted out how we could overcome this problem. They brought up several difficulties with the solution that we'd put forward, namely that there was a pressure area difficulty and that sometimes allergies from tapes arose with patients and were not identified because the patient was unconscious.
We discussed the problem together and we resolved the problem by 2E's, which is a ward here at St George, the cardiac ward. They put an extra armband in the notes, and what we do is we just it's our responsibility as scout and scrub nurses to place at least one armband back on the patient so that when they go to CICU they have a form of identification.
After theatre had begun to implement the change of putting the identity bands onto the patients before they left the operating theatre, we monitored the patients coming back from the operating theatre over a 2-week period. We've been able to ensure that all patients coming back from the operating theatre are suitably identified with an identity band. When introducing any change, it's encouraging to know that the people who've actually thought of the change are going to be involved in the carrying out of that change.
At this hospital, we conduct patient surveys about the food service, usually about once a month. And a survey will get sent out to every patient in the hospital on a given day, and they respond to us in writing. We then sit down and read those surveys and detail common responses, things like that. One of the most common things we were getting back at one stage was a problem with cutlery. Was that often the glassine paper bags we were using were torn, leaving cutlery exposed, which represents a hygiene problem. Also to condiments on the trays, the portion control, salt and pepper and sugar serviettes were often wet, which means that the patient can't use them. So what we then undertook to do was we went to other hospitals to survey other hospitals as to what they do and how they tackle the problem, if in fact they face the same problem. Some did, some didn't. Some hospitals had tackled the problem, some hadn't. With this particular project, there was the food service manager, the deputy food service manager, and the senior food service management team. From there, we involved the distribution supervisors and the other senior supervisors, as well as a handful of the general staff from distribution. We sat around a table and had a brainstorming session. Some of the things that came out through the brainstorming session, firstly, was the fact that we could put the condiments into the cutlery bag. We had our doubts about that first. Under the old system, we actually had staff on the belt specifically for putting on salt portions, pepper portions, serviettes, stirrers and sugar. And through the brainstorming session, we discovered that it was definitely possible to pack these into the plastic bag with the cutlery and thus save some labour on the plating line. The supplier came to us with several different types of plastic bags and supplied us quantities of sufficient of each one to trial them and evaluate and get results. The first few we trialled failed miserably. We then went back to the drawing board and told him what we needed. He then went away and specifically manufactured a plastic bag to suit our needs, and that is the one we have now found to be a success. It's a non-slip plastic bag that's quite narrow in dimension and has a flip-top lid on it so that it can be sealed. Implementation took place via the trial because the trial process basically is all part of implementation. What we had done, we'd got many thousands of each type of plastic bag in, and they had to be trialled, obviously, so that is all part of implementation because we had the staff involvement, they were aware of the project. And finally we came to a product where we had 99% thumbs up. Everyone was really happy with it, so implementation was no great problem. We had no resistance to it, as may be expected with a lot of projects, and it just happened. Since implementation of this new bagging process, we've had no further complaints from patients as far as exposed cutlery or unusable condiments. We also get a great deal less complaint from the dietary staff in that we are now completely controlling what our diet patients are getting as far as sugar and salt goes. As a result of our project, our wastage costs have been lowered. We've saved 2 staff members along our plating line, and the patients have a better quality, much more acceptable product.
The Australian Council on Healthcare Standards has had a profound impact on the quality of patient care delivered in Australian healthcare facilities. From an initial focus on patient safety and staff safety, and also ensuring proper credentialing of medical staff, it's blossomed into a program that encompasses quality assurance, quality improvement, and now, through its care evaluation program, patient care outcomes. Now, the important thing is that it's going to continue to change. Its Charter for Change is all about fundamentally relining the standards by which organisations are going to be looked at. And that means a focus on patient, on outcomes, and on critical processes that occur as a patient's going through healthcare facilities.